Welcome back to Care Transitions Today. This is a healthcare podcast with a focus on case management and transitions of care. Our podcast today is presented by the American Case Management Association, and I'm your host, Deb McElroy. Before we begin today, we do have a brief message from the American Case Management Association. All listeners are invited to join your peers at the 2021 ACMA National Conference, which is being held in Orlando this year, June 22nd through June 25th. This is an important opportunity to engage and learn with case management and transitions of care professionals from across the country. The conference offers a lineup of healthcare experts presenting sessions not only designed to improve patient care outcomes, but also to prepare attendees for success in this ever-changing healthcare system. Learn more and register at casemanagementconference.com. Just a reminder that the theme for this season of Care Transitions Today is centered on innovation in all aspects of case management and transitions of care. The focus of today's episode will be using artificial intelligence for medical necessity and for working smarter to create better case managers, better clinical thinkers, and more patient-focused care. And I am delighted today to welcome my guest, Kim Brady. And Kim comes to us. She is the System Director of Care Management for United Health Services. She comes with more than 30 years of healthcare experience. And I'm going to invite you, Kim, to give us just a little bit of your history and your current role as we dive into the subject.
Thank you, Deborah. So I'm the System Director of Case Management at United Health Services. We're located in upstate New York. I oversee 4 hospitals. One is a critical access hospital. We have a second hospital that is rural, that carries a census of less than 15 patients a day. And then we have 2 primary hospitals. One has behavioral health component there, and the other hospital is a level 2 trauma center. So between the 2 main campuses, we carry about a census of 300 patients a day. Currently, I oversee nurse care managers and associate care managers that are doing the discharge planning and utilization management on the floors, as well as a social work team.
Okay, well, good. Well, keeping you busy, it sounds like, in these difficult days, yeah. Right? Good. Well, let's dive in, because you've implemented a new innovative tool to help nurse case managers. And that's one of the things we want to talk about today. And the tool helps nurse case managers perform utilization review. So can you describe that in more detail? And then can you talk about how artificial intelligence plays a role in all of that?
Absolutely. So our nurse care managers wear multiple hats, but obviously the one thing that we always need to do is make sure patients are meeting medical necessity while they're in the hospital. And it's that, are they an inpatient or are they an observation patient? And prior to implementing the software technology using the artificial intelligence, they would spend 3-4 hours a day just reviewing charts, clicking boxes to make a certain criteria meet. And, they would print out a census in the morning, and they would start at the top and get to the bottom by the time they left for the day. But that patient that they looked at 8 o'clock, 9 o'clock in the morning, that was maybe just an observation patient, by 3 o'clock in the afternoon had gone through multiple test results were back. They've gone to stress tests. Well, they're not looking at that case till the next day. So, and our other thing is we're using one criteria, other payers are using a different criteria, so you're not even speaking the same language. So we saw a demo of the artificial intelligence, and it just made sense. It predicted an observation and an inpatient. What you still needed your nurse skill to use your critical thinking to determine, is this patient really going to stay past the second midnight? But it was a tool that could be used that would give the nurse the information they needed right up front. And it really was a huge difference when we implemented the artificial intelligence software for our team.
So that's great. So I want to dig into that a little bit more. So it allows the nurse case manager to be more efficient, it sounds like, be able to do the decision making. And it sounds like you can then selectively go and review more of your high risk patients. So, can you talk a little bit about that efficiency? And then also, I'm assuming it then lets the nurse case manager spend more time with patients. So can you talk about the impact?
Absolutely. So the software generates what's called a care level score. And that care level score ranges from 0 to 157. And a score of 75 below is leaning more towards observation. And a score above 75 is leaning more towards inpatient. So it really would give a score for the patient, the nurse care manager, based on the patient's clinical presentation. It takes into effect patients' comorbidities, lab results, vital signs, and it really eliminated the need for them to be digging for all this information through the medical record. It still was important for them to look up different things related to the patient, how they were progressing with their lung sounds and different nursing assessments, but everything kind of flows into the platform and it's in one place for them. So based on that care level score, it also highlights patients that are in conflict. So if there's a physician order that they're saying the patient should be inpatient, but the artificial intelligence is saying, hey, I think this is wrong, it would prioritize the cases for the nurse care manager to come in. It's called status conflict. So there'd be patients that were in status conflict that were inpatients that needed to be observation and observation patients that needed to be inpatient. So we implemented this back in 2018. And the first week, by day 3, we were having a debrief at the end of every day. And my team is usually very vocal of what they like and what they don't like. And the third day in, they were very quiet. So finally I said, listen, what is going on? Do you guys not like this? Because change is hard, right?
Right.
It's hard for all of us. And the software team was there. So I felt maybe they felt uncomfortable talking in front of them. So finally, one of the brave nurse care managers said, I think we're doing this wrong. And I'm like, what do you mean you think you're doing this wrong? We're rounding. You guys are doing great. We're being told that you guys, are implementing this the right way. And so the nurse said, I think I have like 2 hours extra in my day.
Oh, wow.
And so everyone around the room is like, yeah, I think I'm doing it wrong too. And really what that meant for us is, they were spending all this time sitting at a desk looking in a medical record. We really got them back to the bedside. They were able, within a few weeks of implementation, they were rounding on every single patient at the bedside every single day. And as a nurse, seeing a patient in person instead of looking them on paper, you pick up on a lot of things. They were able to drive patient care. They saw if a patient had a Foley in, then they could talk about that in case conference. So it really improved our discharge planning for patients also.
That's awesome. So I mean, that's a lot of time. That's a lot of found time, right? Back in your schedule. So you said you implemented like around 2018. So I'm curious, have you continued to monitor, efficiency or productivity, or do you do a check-in with that? Have those results sort of stood the test of time?
No, they really have stood the test of time. I think out of having that, what we want to say, extra time, or maybe they're working more efficiently, I think we were able to work on case conferences. We had a better case conference. The nurse care managers weren't rushing through that time. More time to have those quality conversations with physicians and build those care transitions. With COVID this year, one of the things that we did do early on, because there was so much communication that had to happen with families because they were not allowed into the hospital, is we did pull the function um, away from the floors because there was just so many pieces going on and whatnot. And we were able to, within 24 hours, we just have 2 nurses that are doing the for all our hospitals. So they do reviews on all of our patients. They send information out to payers. So it's just allowed us to just have the floors just worrying about developing good care transitions and discharge planning and really communicating with families, because I think everyone probably thought through COVID, oh, we won't have families here, we'll get more done. Well, for case management, it causes a lot more work not having families at the bedside and truly understanding what's going on with the patient and involving them in discharge planning and care for their loved ones.
I can certainly see that, and actually, I'm curious about that because we've had some previous podcasts and really talked about how organizations had to respond during COVID to some structural changes that made them more efficient, that made them more responsive to patients and families. So, certainly we're not through all of it at this point, but you've had some of those changes in place for a while. Have you continued that structure where you pulled the out and those 2 nurses? I'm just curious, is that current today?
So we have continued it. We're in upstate New York, so the COVID surge really did not hit our area until September. And our max capacity for COVID patients was probably mid-January. So we're just starting to decrease our COVID volume. And we're starting to talk about, do we continue working this way? Do we move the back to the floors? And the reason is we do feel, since we've kind of pulled it back, that maybe there's I don't know if the right word's disconnect, but we do feel that the floor nurse care managers aren't coming in first thing in the morning, looking at their OBS cases and having those discussions with the physicians to get them upgraded. So we're still in the process of deciding whether we continue this way or not. But one of the other good things that did come out of COVID for us from a utilization management standpoint is one of our payers recognizes the software that we do, and we've been able to use the software platform to communicate with payers. And we're having discussions with other payers also, and we're trying to do what's called precision So if there's a score of 100, that patient is agreeable with the payers that it's just going to be inpatient. One of the things early on that we did was we did reviews on all patients. One of the things that we did increase with efficiency after we got more adjusted to the artificial intelligence is we tell our team a score of 100 at this point. We're pretty confident that that case is going to meet inpatient for medical necessity. And there's enough information in there if we did get a denial that we're able to, win on a peer-to-peer or overturn on a written denial, that we don't even do a review on that case unless the payer's asking us for some information. And that's made our team more efficient also.
Yeah, I would think it's stratified, a little more focused. So
Yeah.
I just want to do a couple of follow-up questions on that too. So I'm thinking about your role responsibility, and you mentioned using assistants as well as the nurse case manager. So for those folks, obviously we've had some waivers from CMS associated with COVID. So when you're getting a score, maybe not 100, where you have some clearer direction, as you just discussed, but if you get something that's like a 75, or that's right on the fence between observation and inpatient, like who is seeing those folks, or how do you approach that so that you still have that stratification for high risk, but you're not losing anything?
Yeah. So, a score really from 70 to about 90, you really do need to use that nursing judgment and understand what processes happen in the hospital, how sick that patient is, and really use that critical thinking to really determine upfront, okay, I have a score of 75. It's saying it's leaning more towards inpatient. But I know that with everything we have in place, we should be able to send this patient to CAT scan, give them some IV fluids, and get them out the next day. So we're going to leave that as an observation case. And then really what the artificial intelligence software does, so the nurse care manager looks at that case, let's say 10, 11 o'clock in the morning. They're reviewing these cases on their dashboard before they leave for the day. So say maybe there's a test that came back that was out of range and vital signs happened, or the patient had a rapid response since they looked at that case at 11 o'clock. The system will tell them, okay, you have this patient that's now observation, but really the artificial intelligence is now saying that it should be inpatient. So that team can look at that case again before they go home and be like, oh yeah, I think there's enough here now to upgrade that case where there wasn't 2 hours ago.
Yeah. Well, that's interesting. And the other follow-up question. So obviously communication with the payers, it makes life easier. Does this facilitate in any way communication with your other partners, like your post-acute network or anything like that? Or have you not applied it in that way yet?
We have not had to apply that in any way to our post-acute networks. There's not a way to send like a referral or anything.
Okay.
It's really just utilization management. The one other thing that we do use the software for is, that care level score really does indicate how sick a patient is. So a patient that has a score of 157, that patient's really, really sick. And it really does help the team realize with these scores, okay, this patient had this event, was sick, met inpatient for medical necessity, but we really talk about the higher the score, if that patient doesn't need post-acute services for a skilled nursing facility, that's probably a patient that really is going to need some type of home care. They had some type of event. So it really helps the team also understand what was going on with that patient. Should we put home care around this patient? The patient doesn't qualify for home care. Can we get them into some type of navigation to prevent that readmission from coming back in to the hospital?
Oh, that's excellent. In terms of, so as you're evaluating the tool, and I'm assuming as you decided to embrace this tool, that there was some validity studies done on that previously. Is there any financial component to this? Are you able to quantify financial benefit to the organization in any way with the use of that tool?
Absolutely. Don't we all have to show return on
Yes,
investment
we do.
everything we do? So we monitor what our observation rate was. Pre-implementation, we had done some physician education about inpatient and observation. Probably March of 2018, our observation rate was about 29%. We had done some education. We were down to about, somewhere 23, 24% we were running for observation prior to implementation. After we implemented, we consistently run below 20%. Prior to HIPS and everything coming off the inpatient only list, our observation rate would be 15, 16, 17%. And really our return on investment was about $1.1 million a month after implementation of the artificial intelligence. And that's just from a observation to inpatient conversion rate. That's not the benefit that we also had with having the nurses at the bedside. We saw a little bit of a decrease in length of stay, but we had other initiatives going on, so we didn't really contribute the implementation of this to length of stay. But I do feel, because they're at the bedside, it probably had some impact of our length of stay also.
So I just, just to make sure our listeners caught that. So it was about 1.1 million per month.
Per month.
And did you evaluate that in a defined time, or I'm sort of assuming you do that on an ongoing basis?
Yeah, so the first 6 months, we really were monitoring and contributing our conversions and to the 1.1 million. But as our observation rate just kind of stayed consistently, we really feel that we've been able to maintain that because the nurse care managers can prioritize their cases. It's a ongoing review that's going on for you. It's no more clicking boxes and trying to get the light to turn green. It's concurrent information that's being driven by the care that we're giving to these patients. So
that's great. And just from a provider perspective, physician perspective, or if you use advanced practice folks, that this is, I'm assuming, has been embraced by everyone in the organization, including the providers?
Yeah, so we do talk to the providers about the care level score and why this patient's meeting medical necessity. Our physician advisor can use the artificial intelligence software we saw an increase of winning peer-to-peers because, we talk to the managed Medicare payers, it's about what that patient looked like at presentation. We have the advantage on day 3 to be like, okay, this patient left within 48 hours, but what did that patient really look like that drove that medical necessity? And you can, it gives you a timeline of the patient came in at 9 a.m. and now 2 days later you're getting called. You can say at 9 a.m. what was driving that medical necessity for that patient. Their temperature was elevated, their heart rate was elevated, and their troponin or, whatever medically was going on with that patient. And you can talk to that much better to overturn those denials with peer-to-peer for our physicians.
And I've heard the comment more than once about, for instance, the managed Medicaid population, where in terms of planning for their transition to another setting, sometimes there were a lot of voices. So I'm assuming, just with the increased communication and something a little more quantifiable, that's helping just in the disposition plans as well.
Absolutely. Yes.
Good. This podcast is brought to you by the American Case Management Association. ACMA invites you to join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Memberships allow you to gain access to resources like the Collaborative Case Management Journal, which is a bi-monthly peer-reviewed digital journal dedicated to all things case management and transitions of care, and is available exclusively to ACMA members. To learn about the journal and more, visit www.acmaweb.org/membership, and that is www.acmaweb.org/membership. If you were going to, again, for the folks that are listening, if you were going to go down the list of key outcomes that you saw, I mean, you've been talking about, some really significant outcomes, and certainly the financial ROI is significant, but other things that you think were key outcomes that you would want to share and summarize?
I absolutely feel that the nurse care manager satisfaction is a huge outcome that we didn't really anticipate. With change, you always think that there's going to be a lot of resistance to it. But I think having them not sit at a computer and go back into patients' rooms and be able to not feel that they're rushed, that was huge. Huge early win. I think it made a lot difference in their job satisfaction, and they didn't feel like they were getting pulled in multiple directions. They had a tool that would predict to them medical necessity, and it was really about driving the care. Obviously, the financial impact was really because we were able to do more conversions. So the observation rate went down. And we did see decreased denials because the nurse care managers were getting the patient in the right status up front. And then our overturn rate, as we kind of talked about also, we were able to increase our win rate on peer-to-peers because the physician doing the peer-to-peer had better information. So I think those are our biggest outcomes that we saw from the implementation.
That's great. So just as you're thinking about, and I'm not sure anybody's really at the point where they're totally catching their breath, but it sounds like as recently as January, you were impacted with COVID, and you've got, some new tools that have produced great results. But just as you think about your role as a system leader for case management, just any reflection on where you're at today as you continue to navigate COVID, as you continue to try to get these nurse case managers where they need to be, which is with patients, just anything from the seat that you sit in that you would want to share.
Sure. I think COVID has really allowed us to look at the work that we're doing every day, whether it's from a care management perspective or delivering care, to ask why. Why are we doing it this way? Should we continue to do it this way? Because we all needed to, when we were maxed out, decide if we could do things differently and more efficiently. One of the things that we've done here at United Health Services that, we had early conversations, but basically treat patients that are really hospital level care patients in their homes for COVID. Our performance improvement team around Thanksgiving was predicting the inpatient volume of COVID to be something that we just felt would be unmanageable. And we were able to build processes in place to treat patients in their home. We kept a lot of patients in their home that were on high flow O2. CMS put into effect a waiver for hospital care at home, which we did just apply for, but we've treated 114 patients in our hospital care at home program. Probably over 40% of them have been an inpatient level of care that
Wow.
we would have never thought that those patients were appropriate to stay at home with high flow O2 and whatnot. But we were able to, between virtual visits with physicians, virtual visits with nurse navigators, really treat in place. And, patients were very happy to do that. They didn't want to come to the hospital. So in March, we started enrolling non-COVID patients for different diagnoses. So we're going to continue to work on that, trying to reinvent our care models. And I think partnering with some of our payers, we've been talking to them about the work that we're doing is certainly important because I think we're kind of all in this together to provide a better care to patients at a reduced cost, and we're never all going to get through this.
Right. Well, and innovation, as I said at the beginning, is really what we've been focused on because there's nothing like a crisis to drive it when there may have been some inertia before. I'm just curious as you talk about, significant hospital care at home program. Any additional comment on how that's affected your nurse case managers or social work or any of the folks that you interact with? Has there been a impact on their role?
So in order to care for these hospital care at home patients, we had nurse care managers that were in the emergency department. When our emergency department was at peak census, they kind of overtook every nook and cranny, and our nurse care managers were kind of, I wouldn't say they were pushed to the side, but their space was used, right? There was still a need for them. So we kind of realigned the work that they were doing, and they're really navigating these patients that are enrolled in hospital care at home. They're calling them every day. They're arranging transportation if transportation is needed for something. They're getting DME into the home. And it's been really using the same skill set that they already had being in the hospital, but doing it remotely to patients. It's the same skill set, but just doing it a little differently. So yeah, we've all had to adjust to the work that we're doing.
Well, it sounds like as a team, you've really responded to the need for change, even pre-COVID, and with some success. As we're wrapping up here, any final thoughts that you would want to share with the folks that are listening as you look to the future? Again, you're in the midst of innovation, but as you look to the future, what that looks like to you?
It's just really important to always be looking for asking that question, why are we doing this? And does this make sense? How can we do this differently and more effectively? I think the more flexible and adaptive that we can be, and I think that's, part of being a nurse anyway, right? We're all flexible and adaptive and able to pivot in the moment. And I think that keeps things in the forefront of what we need to do for patients.
Agreed. Well, Kim, thank you for your time today. I think this is important information for people to know as we're trying to be, deliver, you just said, cost-effective care efficiently. So thank you for joining us. And To our listeners, we hope you've enjoyed listening to this podcast. We'd love to hear from you. If you can, we'd love you to leave us a rating and a written review so that we know what you think. And don't forget to subscribe to the podcast, to Care Transitions Today, so that you're notified when we have new episodes. Stay tuned for our next episode as we continue our innovation series.